Hi everyone, and my name is Nan, and one of the nurses in our community nursing service. I will be presenting the International Working Group on the Diabetes Food Guideline on the intervention to enhance healing of the food ulcers in persons with diabetes. So this guideline is relevant to our work, and I would like to suggest to implement 3 of the recommendations. So firstly, let's look at the objectives. So by the end of this section, I would like everyone to understand the wound healing intervention pathway of the diabetic foot ulcers and the relevant treatments within our community nursing context. Also to improve our role in delivering recommended treatment in a community environment. So a bit of background first. So diabetic foot disease is a major health concern in Australia. Each year, there are around 50,000 of Australians affected by the diabetic foot ulcers, with around 28,000 individuals admitted to the hospital, and many of them require amputation. The International Working Group on the Diabetic Foot has been publishing guidelines on the prevention and management of the diabetic foot disease since 1999. The guidelines are widely adopted in Australia. And since their last update in 2015 on the wound healing interventions, the number of published clinical trials have increased with a number of important developments in this field as well. Therefore, an update of the guideline is released in 2019. And this updated version evaluates current available evidence on the treatment and to provide us with 13 recommendations. So let's have a look at the key recommendation they have. So debridement, sharp debridement is the preferred method. And the wound dressing selection. So dressing should be chose based on extra day control cost. And when the treatment goal is to accelerate healing, topical antimicrobial is not recommended. And the sucrose octane in pregnant dressing is recommended for non-infected neuroischemic heart failure diabetic foot ulcers. And for the oxygen therapy, the hyperbaric oxygen is recommended for ischemic ulcers. Topical oxygen is not recommended. The negative pressure wound therapy or the VAC dressing is recommended for post-surgical wounds, not for the non-surgical wounds. The adjunctive treatment or and the alternative products and agents altering the physical environment and agents correcting nutrition status are either not available in Australia or not recommended. So we are not going to talk about them. For the application, so recommendations on sharp debridement, dressing selection, and a VAC are the most common and relevant to us. We are already using the time principle to select dressing and avoid antimicrobial on the non-infected wound. So implementing the sharp debridement, sucrose octane dressing, and the VAC are the most in need. So looking at our client, majority of our clients actually are referred by their podiatrist and the vascular team, and they are still under the care of their specialists and having regular reviews with them. Before coming to the community service, their wounds are usually investigated and a diagnosis are usually provided to us. And the referral usually give us the wound treatment plan for us to carry on in the community. And the most common intervention we are seeing are sharp debridement, the sucrose octane dressing and the VAC. So currently we have a couple of problems. So at this moment, the client in the community only have their sharp debridement done with their podiatrist. So sharp debridement is just to be done every 1 to 4 weeks. So when the client needs frequent sharp debridement, they often have delayed treatment or inadequate treatment because many of them have certain disability or busy lifestyle, which prevent them from attending to their podiatrist in time. Also, the sucrose octane dressing is not initiated on time. And this treatment usually don't get started until the client sees their specialist, which can also cause delayed treatment. So many of our nurses are actually very good at doing the VAC dressing changes and able to report changes of the wound. However, the clinical endpoint of the VAC are sometimes unclear, which can affect the effectiveness of the treatment as well. So therefore, it's important that we implement these 3 recommendations and ensure our nurses understand and able to apply them correctly and efficiently in the community environment to improve our clients' health outcome and the quality of lives. So to the implementation, we will look at the pathway first. So following the diagnosis, wound dressing are selected based on the wound bed preparation principle with the aim of removing non-variable tissues and exudate control. Comfort and cost should also be considered. The presence and severity of the PAD will determine if sharp debridement can be done. So when PAD and pain are absent, sharp debridement can be used to remove non-variable tissue and collects. However, if the patient have severe PAD or pain, extensive sharp debridement should be avoided and suitable dressing should be used. For post-surgical wounds, VAC can be a good option. Wound review should occur in 4 to 6 weeks. If the ulcer is healed, patients should go on to preventive measures. If the ulcer is improving, care should be continued with 4 to 6 weekly review. And when the wound is not healing, a review of all best standard of care is required, and adjunctive treatment can be considered. For ulcer without severe PAD, the sucrose octasuffate dressing may be initiated. For the ischemic ulcers, hyperbaric oxygen therapy can be discussed with the patient. So for the implementations in our workplace, the priority of recommendation we are going to implement are sharp debridement, the sucrose octasuffate dressing, and the VAC. So the goals are minor conservative sharp debridement can be delivered in the community by the competent nurses. And the sucrose octasuffate dressing will be initiated or discussed in a timely manner. Confusion on clinical endpoint of the VAC is avoided. There are some barriers. Firstly, the sharp debridement can only be done by the wound nurses at the moment. The limited number of competent nurses is a barrier. And the sucrose octasuffate dressing is a fairly new product, and many of the nurses are not very familiar with it, which reduce their confidence in starting this treatment. So currently, this dressing is supplied under the name of Rolling Star, which needs to be ordered through our admin staff. So the accessibility is another barrier. And our referral are mostly from local hospitals or the podiatrist clinic. They are working in a busy clinical environment where efficient communication to discuss the VAC dressing can sometimes be difficult and inconvenient. There are a few things we could do. So there will be more training section how to upskill senior nurses for minor sharp debridement. And education section will be held to introduce the ErgoStar dressing. And ErgoStar will be putting into our normal ordering system to simplify the process. And a resource person will be appointed within each team where the nurses can ask for guidance and discuss the dressing changes, the changes of the wound or the treatment before contacting the referrers. And next one is multidisciplinary approach can improve the outcome of the diabetic foot ulcers. So for us, podiatrists and the vascular team are the main decision makers on the local interventions before the patient are coming to us. GP also play an important role with medical clinical skill can be used when the specialists are not always available. So the implementation would ensure the key members of the team are in line with the recommendation where the right treatment is provided, and continuity of care is ensured, and communication within the team is efficient, and the client can avoid multiple trips to the hospital or the clinic. So once the podiatrists are on board with these treatments, they on board with these recommendations, so they can provide debridements, they can decide the schedules, and they can liaise with us or GP with minor debridements in the community before in between the reviews with the patients. And they can also initiate the sucrose octane dressing is appropriate. They can guide community nurses with the VAC, and then they can monitor the wound progressions and the treatment effects, and then adjust the treatment as indicate. And the vascular team will be able to initiate the VAC on time for anyone who had a sharp debridement on the wound, and they can determine the VAC regime and assign the VAC changes to us. And there could be a better communication between us once they are in line with the recommendations as well. And the GP can assist with minor sharp debridement or the VAC where it's required. And they can also provide us with general guidance and assist to us or the patients when their specialists are not available. And then now we're looking at the application. So the first one is the sharp debridement. And the rationale, sharp debridement removes device, non-viable tissue and colloids, which transfer the wound to its acute phase and trigger healing. The slough and necrotic tissue is the ideal environment for bacterial growth. So removing this type of tissue also reduces the risk of infections. So for the applications in Australia, sharp debridement means removal of non-viable tissue with surgical or conservative measures. That an aseptic technique with a sterilized scalpel or scissors is used. Patients with severe PAD or pain, extensive sharp debridement should be avoided. So it's important for us to assess the wound condition and patient's history before we proceeding to the procedure. And any questions on the diagnosis of abnormal funding should be escalated. Also, we don't have many nurses at the moment to do the sharp debridement, so internal referral to our nurses is required. Or the resource nurse can be contacted to arrange treatments between the wound nurses, podiatrists, and the GPs. So the evaluations, the frequency of debridement required, wound progression and healing outcome are the key indicator of the treatment effectiveness. Our service requires weekly wound review where the wound status can be evaluated and feedback to the referral on at least weekly basis. And the next one is the sucrose octane dressing. So the rationale, diabetic foot ulcer have prolonged inflammation and increased level of MMP. The MMP prevents healing, especially in the neuroischemic ulcers, and predict poor outcome. This dressing can actually reduce the activity of the MMP and interact with growth factor to restore healing process. So the application is limited to those ulcers fail to reduce size by 50% within 4 to 6 weeks of good standard of care, and the wound is not infected without severe PAD. The dressing should be used in addition to a good standard of care, and in our service, only the ergostack contact layer is available. The application of the dressing is the same as other standard dressing, where all the nurses should be able to apply it fairly easily. And the ergostack needs to be used for a minimum of 8 weeks, unless the wound is healed during that time. And the dressing should be changed every 2 to 4 days. And a secondary dressing is also required, and it should be chosen based on the wound conditions. So the evaluation is pretty much the same as a sharp debridement, that the wound needs to be, the wound progression needs to be monitored closely. So our weekly routine wound review should occur as our policy to monitor the wound progression, and the wound assessment outcome needs to be reported to the referral every 4 to 6 weeks or PRN. And the next one is the VAC dressings. So VAC dressing use a intermittent or continuous vacuum system to provide a positive pressure environment on the wound. This therapy allows wound fluid to be dried and stimulate granulation and wound contraction. So the application, so the VAC is limited to post-surgical wounds, wound conditions such as variable the skin age and tissue below it, whether there is capillary bleeding, whether infection has been addressed, whether the necrotic tissue has been removed, and the treatment goals and patient factor should all be considered when using the VAC. So VAC should be stopped after the clinical endpoint is achieved. So also in our services, we require VAC dressing to be attended by competent RNs with sterilized technique, and the evaluation. So the wound is just to be reviewed in 1 to 2 weeks of treatment. When there is a daily increase of healthy granulation and reduced depth, a good perfusion without infection, that can be continued until the treatment goal is met. However, deterioration of the wound indicates further assessment, and alternative treatment should be given before the VAC can be restarted. And the recommended clinical endpoints usually are 50% value reduction, 80% of granulation tissue formation, or complete closure. Therefore, when the client is home with their VAC, it's important for us to communicate with the vascular team or podiatrist with the wound progression. So our routine weekly wound review should occur, and the outcome should be feedback to the referrer every 1 to 2 weeks, where the adjustment can be made promptly. And the last one, in summary, we did briefly introduce the guideline on the wound healing interventions and discuss the 3 most relevant recommendations for our community nurses and other departments that we would like to have them involved in these implementations. We also went in a bit more detail for each of the recommendations on their rationale, application, and evaluation. We will be auditing the implementation outcome in about 6 months, just to see how we go with these new recommendations. So we'll be asking feedback from our nurses, the clients, and the referrers. So that is the end, and I hope you enjoyed the presentation, and that's the reference list. So I will be stop here.